Hello, everyone. Thank you for joining. I'm Allison Bloss at the Center for the Economics of Human Development. And just another thanks to Linda Wade and the team at NORC Center on Aging for inviting us to put the workshop together this quarter. This is the last week hosting this series. I think we had a lot of success and great feedback, so we're going to continue some version of it under the umbrella of our center. We also hold other workshop series and other events, so please check out our website. I'll put some links in the chat as well. Some of the videos from the other talks from this quarter are on our website as well. And today we have Dr. Alexandra Brentani. She's a professor in the Department of Pediatrics at the University of Sao Paulo, and she's director of Center for Child Development. I actually don't know the Portuguese name, so maybe I translated it incorrectly. You can correct me. Her work focuses on understanding the impacts on children's health and development and the implementation of interventions for promotion of child development and health, and translation of that into public policies. And today's just going to tell us about some of her studies and the interventions happening in Brazil. If you have any questions, feel free to jump in, just interrupt or add them into the chat. So thank you, Dr. Brentani, and we'll hand it to you.
Thanks. So let me share my presentation. So during these past years, I have been working with the REACH-UP model to deliver home-based visiting intervention in Brazil. Because we lack ECD stimulation and programs, and the poor people that are living in urban or rural areas, they are exposed to high violence, and they become even more vulnerable, and this can increase along the generations. So we decided to implement the REACH-UP and Learn model developed by the Jamaica team, which has weekly home visits to promote parenting practices and early childhood stimulation. The characteristics of the model is that they have a structured curriculum and a toy kit. So every visit, they introduce 3 or 4 new activities that use specific toys and that are age appropriate. And they leave the toys at the home for the practice. And in the next visit, they introduce new activities and they change the toys. So we have been working since 2013 in the process of implementation of a REACH-UP based public policy in Brazil. And I will show you how we have been going step by step of this way. So in phase 1, we started with the adaptation of the curriculum to the Brazilian context. We did that in Sao Paulo, in the western region of Sao Paulo, which is the main capital in Brazil, with a very large vulnerable population. So we worked with 100 families with children from 9 to 36 months, which is the original REACH-UP curriculum. And we had 3 visitors delivering visits for 4 months. So the results of our adaptation process to the Brazilian context, we developed a curriculum that was condensed in 2 monthly visits instead of weekly visits. We had to adaptate the toy kit, the original toy kit. The Jamaican kit is very large, and the families didn't like the appearance of the toys. So you can see below that we had to, all our toys had to undergo plastic surgery here. You can see before and after. And after the testing, we had very good acceptability and viability. We had a very a low rate of dropouts, and the materials were finally evaluated as very good. So the second step that we took was to try to assess the impact of this new curriculum. We conducted the impact evaluation from 2014 to 16, still in the same area of São Paulo. And at that time, we wanted to check two different delivery strategies. So the first strategy that we tested was using our primary healthcare model, which is based on community health agents making home visits. So we integrated our curriculum to the regular home visit of the agent, of the community health agent. But considering that this model doesn't cover all the Brazilian population, they cover only 30% of the population, we also created what we call a child development agent, which is a trained community member that delivers the intervention in the homes nearby his own home. So we used the same materials, the same training, the same frequency in both arms. We delivered the intervention for 12 months, and we used...
Alexandra, could you clarify why? I mean, I'm surprised. You're saying that only 30% of the Brazilian population is has access to or uses the primary healthcare system. Is that correct?
Yeah, no, actually, we have two different models of primary care. So we have one model that is based in home visits, which is called the family health strategy, that covers only 30% of the population because it's expensive. So the rest of the population is covered by what we call the traditional healthcare model, which is center-based. So the population has to go to the center and schedule appointments to be treated or to receive medicines and consultations.
So how are those allocations determined, though?
They started allocating the family health strategy in the most vulnerable areas of the municipalities. But actually the program was, the new hirings were suspended. So we couldn't cover all the vulnerable areas with community health agents, and we couldn't expand the model. So now we have vulnerable areas with both models coexisting.
Okay.
Okay, so the idea was to have a community health agents for everyone, but due to financial constraints, it didn't progress as planned. And that's why we decided to test both strategies. And to assess effectiveness, we used the PRIDI and the Caregiver Reported Development Index as the development instruments. So we conducted a randomized controlled trial in São Paulo with 4 arms. So the first arm was the areas covered by the family health strategy, where the agent was trained and delivered our intervention on top of the regular visit. And we had a control group that was also covered by the family health strategy, but the community health agent proceeded with his regular visit. And in parallel, we had the child development agent in areas not covered by the family health strategy, delivering visits for these children, and a control group of children that were not covered by the family health strategy that received the traditional primary care model, which doesn't include home visits. And considering the proportion of the coverage, we had a higher sample in this second non-visit traditional model groups. So the main result was that the areas where we use the community health agent, we didn't find any impact. And that was because the number of visits delivered was very small. So in a 12 months period, they should have delivered at least 12 visits, but the average number of visits was 2. And this was because they couldn't flexibilize their agenda. So once the family had to skip the meeting, they hadn't the flexibility to reschedule it. The CDA group, in contrast, had the flexibility to reschedule the visit. And what we found is that the intention to treat analysis showed a result that was similar to the other countries that evaluated the reach-up model. And if we look at the treatment on the treated analysis, we will see that the impact was very higher if the children received 10 or more visits. So in 2016, when we finished the impact evaluation, the Marco Legal da Primeira Infância, the legal framework that prioritized ECD policies in Brazil, was created. And in response to that new framework, the president developed our national ECD program, which is called the Programa Criança Feliz, and uses community child development agents through the social assistance units to promote child stimulation through home visits. The program recommended UNICEF's CCD methodology, but it was not mandatory. So our idea was to adapt our reach-up intervention to this new content of the Criança Feliz and test it at scale. And we did that in Boa Vista, in the northern area of Brazil, in the Amazon area. So we had to extend our curriculum. The original Jamaican curriculum was from 6 months to 36. So we created a pregnancy module that covered healthy habits, parenting practices, and alarm symptoms. We also created a neonatal period module covering the first week of life, stimulating breastfeeding and the bonding between caregiver and the child, besides child stimulation. And then together with the reach-up group, we extended the Jamaican curriculum from 0 to 36, including activities for motor development, cognition, language, and social emotional development. So our curriculum now covers from the beginning of the gestation, even though usually the pregnant women enroll in primary care, a new antenatal follow-up during the 21st week of gestation, and the child stays in the program till 3 years. So at this phase of the implementation at scale, we wanted to analyze the cost effectiveness of the program comparing 2 different strategies. So we had regular room visits that we already have evaluated, but we decided to create small group meetings using the experience of the Bangladesh team that adapted Reach Up to group meetings. We also wanted to know if in these group meetings, having this peer support, does it enhances the adherence to the program? We wanted to know if that our pregnancy and neonatal model had an impact on the reduction of neonatal mortality. And we wanted to test what was the best entrance moment in the program as the pregnant woman or the child once the child was born, and when the child was the best moment to enter the program. We are also delivering the model to refugees and the urban population. So we wanted to see which kind of population benefits the most and what is the budgetary impact of this program.
So just to be clear, I mean, in each of these different streams that you're discussing, the same curriculum is used, or how is it adapted across these different treatment streams?
You mean the curriculum?
The curriculum.
So we created, the curriculum is more or less the same. What the difference between the home visit and the group meetings is only the number of activities per encounter. So in a home visit, usually we have 3 to 4 activities. In the group meetings, since we have 8 mothers with their children, it's the process is slows a bit. So we have 2 activities, one language and one another one.
All children are doing the same activities. It's not like
we decided to have the groups with the same within the same age range, so that all children receive the same activity. Yeah.
So all children receive the same activity at a given age. Is that correct? Yes. Yes. So what about a child who shows a lot of development? So the child is, smart or slow or whatever. Do you adapt the curriculum to that child, or do you just impose or use the same curriculum for all? Always?
No, we have two kinds of adaptation. One is that we can turn the activities a bit more difficult or a bit more or easier, depending on the capacity of the child. So for an example, we have if you have a puzzle, you can give only 1 piece, or you can give 2 pieces or 3 pieces, depending on the capacity of the child. For some children, we had to jump some visits ahead. So instead of receiving the 1 month and a half visit, we deliver the 2 months visit for the child, even if she's not 2 months, because she's much ahead of the others. But this is very unusual, actually. Normally, what we have is making it more or less difficult, and that's enough.
But you can record this. I'm just wondering what the strategy is. This is decided on a case-by-case basis by the home visitor, is that right? Or the group visitor?
No, it's decided on a case-to-case basis between the home visitor and the supervisor.
Right, okay.
So, so we have weekly meetings with the supervisors, and then they decide what to do. And all of this is registered in the visit log. So we know which activity was performed for each child at each moment.
Mm-hmm. And there's no, okay. And so the scale, though, you're saying that you can slow it down, you can speed it up, but it's all within a range. I don't know how you determine that range. That's all. I'm just curious what the range of learning tasks is.
Yeah, well, I think it's a very difficult situation. The supervisor has a training, but especially in places like Boa Vista, it's not graduate staff member, so they have to try they have to decide on the capacity of the child by trying to jump one visit and seeing if the child is able to do that or not.
But in the group meeting, would you be able to individualize? The home visit I can see.
Yeah. You know, the idea is that we have small groups so that every child can receive at least partially some individual attention.
I see.
But
And
what we have been seeing in the logs, in the visit logs, is that this is very seldom occurs. And you will see the results.
And so,
of the group
so in the
meeting.
group meetings, they're all more or less moving on the same path. They're all
Yes,
taking,
yeah.
but in the home visits,
Yes.
they're actually personally adapted. Okay, that's interesting.
Yeah.
That's quite interesting,
Yeah.
actually. Yeah, okay.
Yes.
Alessandra,
Yes.
can you clarify
So-
how this curriculum relates to the overall Criança Feliz? Like, what did you design the curriculum for the whole program in the country, or did you use that funding to apply your own curriculum in that specific locality?
No, this curriculum is the Jamaican curriculum. So we extended it together with the Reach Up team, and we use it as intended by the Reach Up program. What we will see in a few minutes is what we are doing now for the Criança Feliz, because they don't have a curriculum. And that's one of the problems of the Criança Feliz.
Okay.
Okay, so what we had to do during the pandemic was to suspend all face-to-face meetings, as many other countries. So we had to develop a remote curriculum, so we selected from the Reach Up curriculum the activities that didn't require specific toys, or that required toys that could be produced at home, and so the home visitor or the group facilitator through WhatsApp, they send the activities that should be done in each visit, and we kept the meetings every 2 weeks. And after they send a photo of the activities, they have a phone call with the family where they explain what is to be done, where they ask about the child, and they get the commitment of the practicing for the next 15 days.
We have a question from the chat. Fanmei would like to know who are the supervisors and what are their qualifications, and how many home visitors or families that supervisor would oversee.
Yeah, so one supervisor is responsible for up to 15 community agents. And initially, we required that the supervisor had a higher education level, but in practice, we couldn't find eligible people for that in Boa Vista. So we have supervisors that do not have a graduate level, and we had to train them, not only on the methodology, but also we developed a supervision training module, and we follow them closely. We used to go to Boa Vista once a month to follow up their activities. Okay. So because of this new WhatsApp module, we created another arm of our study design. We used, initially we used a step wedge design, and allocation was based at the neighborhood level. So we randomly selected the neighborhoods that will receive home visits, neighborhoods that will receive group meetings, and the remaining neighborhoods will be our control. And after 2020, we selected a part of the control group to receive the remote meeting, so that we guarantee that we have children that were not exposed to face-to-face meeting and are only exposed to the WhatsApp program. So we started the delivery in 2007, by the end of 2017. The first children were born in February 2018. And we are now conducting our end-line assessments with children that have completed 2 years. We also we are also using the administrative birth and death data systems to assess the fetal neonatal death reduction. And we are using the family care indicators to assess parenting practices improving, because we had to conduct our end-line assessments by phone.
Can you amplify a little bit, Alexandra? I just wonder if you could clarify a little bit more. It's been discussed, but I'm not certainly completely clear. The remote visit, these remote, I mean, so the remote, are the parents reading the app? Who's being contacted by the app and who's implementing the lessons?
Yeah, so the agents that use it to perform the visits or the group meetings, they send through the WhatsApp a photo of the activities. So we created a curriculum with photos so that they send to the parents that the activity that should be performed in that 15 days. And so the photo has the activity, what is the objective of the activity, what has to be done, if there is a toy that if it requires a toy, what toy they need, and how they can build this toy. And after sending this information, they make a phone call or a FaceTime call. And then they discuss with the family, so the agent discusses with the family about the activities, and it's very similar to the face-to-face visit. It has the same steps, but it's made through phone.
Through the phone, I see. And
Yeah.
is the compliance rate the same? In other words, if you go across these different the group meetings, the home visits, and the remotes, in each case, parents are being exposed to some idea, some way to treat the child, but how many actually implement it? The remote data seem to be asking, not only do they get it, but do they act on it? Whereas it looks like the home visit data and the group meetings, you don't know if the parents actually implement it, do you?
Well, we ask them. We ask all of them, how did you practice during the last 2 weeks, and how many times did you practice?
I see.
So
okay, so
every time they fill out a visit log, they ask it.
Okay, so you're comfortable with the fact that you're getting a comparable assessment of parental input across all three streams.
Yes. Yes.
Okay.
Because after asking, we tell them to perform the activity with the child. So they also evaluate if the child is being able to do that. So if they really perform the activities during the period within the visits, then the child should know how to do that. So we ask them to perform it.
So do you get a weekly or bi-weekly assessment of the child in each one of these streams? Bi-weekly.
Yes, yeah, after each visit.
So you know exactly whether the child is able to perform the task.
Yes,
I see.
yes,
Okay.
and we
Yeah.
do that in the remote module as well.
Okay. Okay. Interesting.
So yeah,
Professor?
no, I think yes.
Yeah, I have a question. Can you elaborate on the outcomes regarding fetal death reduction? I think from what I read, you only keep track of like neonatal death of babies after they are born, right? So although you follow pregnant women since the first trimester, but you don't have data on percentage of stillbirth, right?
Sorry, I cannot hear you. You are speaking
It
very
might be
low.
the-
Can you speak a little high?
Yeah, it probably is the mask. Hopefully I won't be catched for violating the rules, but anyway. So you keep track of pregnant women since their first trimester, but I don't think I read any data on regarding the percentage of stillbirth of babies. That means that babies who are born dead in your studies. Do you have any information regarding that?
Yeah, we keep the records of births and deaths, and we are analyzing the impact on child mortality in two different ways. The first way is using the municipalities' administrative data, so we know in which neighborhoods we have randomized the intervention. So we are assessing the mortality rates by neighborhood. So and we know when we started implementing the strategies, and we also are analyzing the deaths and the miscarriages within the groups, the control and the intervention groups.
So you can find like death reduction in both types of cases,
yes,
right?
we hope. Yeah. Yeah. Our only concern with the remote module is that we also have this problem with the other groups, is that mobility is very high in Boa Vista, especially because we have a lot of refugee participants. We lost many participants during the pandemic, and we couldn't reach many of them by phone, probably the most vulnerable participants, because they don't have a phone. So I was saying we have very preliminary results. But what we see is that if we consider the home visit arm, we didn't assess the remote arm yet. We are assessing it because we started delivering the intervention much later. So we are going to assess them in the beginning of next year. But what we have seen is that we had a nice impact on the home visit arm, a bit higher than the one we found in São Paulo, in the overall development, and in motor and language development, as well as social cognition. And we didn't find any impact on the small group arm. But this result, yes.
Hi, Pam here. I was wondering, like, do you have any idea why the center base wasn't having any impact, or even I know that it's not significant, but the negative numbers, and then also maybe why the social emotional in the home visit is not showing? This is after 2 years?
This is after 2 years.
Yeah.
Because we are we are assessing kids that we didn't consider the pandemic, because the pandemic was very difficult. So we assessed children that reached 2 in 2019.
Yeah. So do you have any idea why the center-based didn't have impact?
Yeah. Well, the center-based was not as the assiduity of the meetings was not as high as the home visits. So we have people that skipped more meeting, and this is something that we imagined that would happen. So people have to go to the center to receive the intervention, and they do not attend as many meetings as the home visits, where we have someone going to your home. And in addition, we have the municipality decided that they wanted bigger groups. So we have groups now that instead of 8 families, we have groups of 13, 15 families. So I think that individual assistance is very limited, and so maybe that's why the groups didn't work.
Because in our Indian study, we also have like less attendance. It was like 50% compared with around like 80% at the home visits, but we have got the same impacts statistically. But yeah, like our groups were maximum 8 children. So maybe it's like the number of children. And I don't know if you can do an analysis looking like small groups and big groups in your data. Some heterogeneity, because it seems like you have like enough power, I will say, to actually test that. But maybe that could be
that's our idea. Yeah. And especially to look at different populations, because it seemed for us that refugees from Venezuela, they liked the group meetings more than the home visits. And this is maybe because they had the peer support, or because they really didn't have a home where they lived alone, so that they could receive the visits properly. So we intend now to analyze the data in further detail, and we are still collecting more data so that we can deepen our analysis.
But Pam, go ahead, Lucas.
I just want to ask a question about what was the minimum detectable effect that this experiment was kind of geared towards. And like, I understood the randomization was in the neighborhood. So I'm thinking if what was the power or the minimum detectable effect, especially considering this randomization, like grouped.
Yeah, we were looking for an effect size of at least 0.15, which was the one found in previous studies. And
do you have like data on people who attended enough, like have enough attendance for the center-based study? I remember in some previous slides you talk about the effect is quite significant. In previous slides, you talk about the effect is quite significant for people who attended more than 10 visits, right? So do you have data on, like, for the center base, maybe you can make a subset of only parents and kids who attended beyond a certain threshold of visits?
That's why we are going on with the end-line assessment, so that we increase our sample in order to be able to analyze subgroups. For now, we have only 1,000 assessments, so we couldn't analyze it in more detail. But the idea is that as we have more, we will be able to analyze in terms of the frequency of attendance, in terms of different populations, entrancy in the program, which is something that we discussed, Professor Heckman, when we were planning this analysis. So the idea is that once we have more data, we can think about different approaches of analysis.
And will you have any idea about how to incentivize participation in the center? Because I can imagine it's much more cheaper to conduct the intervention at the center.
Yes.
Maybe if you can pay a small price to incentivize people to go to the center, maybe that saves a lot of money. Then maybe it will help scale up the
Yeah, that was one of our main driver to try this center-based intervention, because while in a home visit, one agent can be in charge of 30 to 35 families. The most in the center-based arm, I can have like 240 families. So our idea was, well, let's see if it makes a result, and then this will be a much more cost-effective approach. But we still we know that there were many problems in the implementation of the center-based, and we can analyze it because the implementation was different in different neighborhoods. We know that there were some facilitators that were much better than others. So the idea is that once we have enough data, we will be able to perform all the analysis again and see if there is a difference.
Yeah. So something that it will be nice also, like, is maybe, because at least for us in India, well, and in several projects, every time that we include maternal education, some of the impacts disappear. So I was wondering, like here, I don't know if you control for those other type of characteristics. But yeah, I was just wondering. And then also like multiple testing, if you are separating. I don't know which criteria are you using, but some of them like have like very few items, no? Like you ended up with 10 items for cognition, or with 15 items for language. So maybe sometimes like the credit is much better to do it like just globally, you know? So maybe you will get more information, and it will be, maybe you will get, well, I don't know, like I'm just saying in terms of also significance once that you start analyzing by subgroups. So we have two papers for the credit, one for the long version and the short version. And the short one, normally we suggest that it's much better to use it as an aggregate and overall. But yeah.
In this case, we are using the long form because it was intended to assess the program evaluation. Yes, so we use that, but we also have a problem of performing the assessment by phone. So we had many families that didn't answer correctly. The idea is that now, in the beginning of next year, we will be able to go there and perform observational and direct assessments, so that we will improve the quality and validate the data that we collected so far.
And Alexandra, just to pursue this point that Pam is making, it's a good point, but I guess a series of points, but these are treatment on the treated, or this is intention to treat? I mean, how are you dealing with the non-compliance, especially this non-response to the assessment data? So there are two different issues. Do they show up? And then do they give you data? I mean, those are for different streams, I understand. How are you dealing with that?
Yeah, no, this is intention to treat only. So
that's a huge problem here, though, right? Especially if you get attrition or non-response.
Yeah. So now what we want to do is to work on the treatment of the treated analysis, so that we will see what happens for the ones that really participated, and we can go further in this analysis using controls like maternal education, as mentioned by Pam. This is the very preliminary analysis.
No, I understand. I think it's very nice to share it with us, but I'm glad that Pam is on the line here because there is some real issue. She mentioned the fact that in India, the center and home visits were both effective, equally effective, or within statistical fluctuation. But was that treatment on the treated or intention to treat?
So we did both analysis because we actually at that point, like we have the data on like attendance and everything, so we could compare. It's not the case that Alexandra doesn't have it yet.
I see. Okay.
So we also analyze it by subgroups, as I suggested, and adding like, we also did like multiple testing and all the stuff like to actually confirm like parental education. And then we even like try to analyze boys and girls and stuff like that were relevant in India, the order of the child and so on. But yeah, for that reason, I was suggesting, Alexandra, there are times that sometimes when you do those analyses, it helps you to understand what is happening.
Yeah, sure.
No, but I thought in Colombia that the center-based care was not that effective. Is that a misreading?
Yeah, well, the one that I was mentioning, it was in India.
No, I understand. But I thought in some earlier work, I think Costas told me that the center-based care was not really that effective.
Well, it's just that in Colombia, it's not the same curriculum. It's like and it's also like a preschool intervention. The one that we did in Colombia using the ReShap, which is the one that is shown here also, it was only home visiting.
Only
and
home
the numbers
visit.
were very similar as these ones, like 0.3, well, between 0.2 and 0.4, and actually language was much better than cognition. Well, not much, but like a bit better in terms of the impacts. But it was just like home visiting, and it was the first thing that we start doing, like the adaptation of ReShap.
Okay.
Yeah,
the other programs are different. Sorry, I was just saying, like the other paper that you are saying, Professor Herman, they are different. They are the ones from EIUA, EI2, or something like that, like a different program that Costas has with Horacio and with Raquel Bernal, in fact, I think.
Raquel Bernal was part of it. That's correct.
Yeah, exactly. They are different programs. It's not the ReShap.
It's not ReShap. Okay, good. No. I misunderstood. Maybe it was just an informal conversation. That's very helpful. So you're getting qualitative the same estimates from home visiting in the Colombia program.
Yeah, if I compare this one, even with the Indian and it's very similar between the Indian, the Colombian, and the one that we have here in Brazil. In fact, now with the ReShap team, and then I give you the time to you, Alexandra. In the ReShap team, we are working now in a meta-analysis paper with almost like 15 or 20 papers that we have, adapting ReShap with different arms also globally. And we hope that we will present that very soon in the pediatrics, because we send it to the pediatrics journal, but we are working on it currently, in fact. And the results are very similar in most of them. There are some like outliers to the right and to the left, but the mean is around these ones, I will say. And it's normally like language is much better than cognition. And then social emotional is like more difficult to evaluate it because there is not a consistent measure. Like there are not so many that actually use CREDI, as maybe Alexandra will know, like because CREDI is also new, like most of them use Bailey or other type of direct assessment instead. But now, of course, we are in a COVID context. So there are things that are not, that we cannot measure anymore in person.
Yeah, can you send that around when you get the meta-analysis done? I'd be very curious about it.
Yeah,
sure. You guys have this whole cluster, and I'd be very, very anxious to read it, actually.
Yeah, sure. No.
Because I guess in principle, we could contribute the China study too, if you want it.
Yeah, well, it is included. We will send you like an email soon to your team to get some of the values, but yeah. The Brazil one is also like the Brazil one is also included, as Brittany, maybe Alexandra know as well.
Yeah,
yeah. And I stopped.
Okay.
Sorry, Alexandra.
Okay, no, good,
Okay.
thanks.
So, and in terms of the family care indicators, we also could see a difference, a small difference in the home visit arm, and no difference between the center-based and the controls. So what we are doing now is that we are working with the national, with the implementation of the national program, the Programa Criança Feliz. The program has been implemented in 2,900 municipalities, which represents 70% of the eligible municipalities in Brazil, and it targets 2 million children, covering urban and rural areas across Brazil. And there is also another component, which is that the program is offered to indigenous and other traditional communities. So as I mentioned before, they didn't have a formal curriculum, and we have been working since February in a partnership with the Ministry of Citizenship, funded by the Lego Foundation, to create this curriculum for the program. So the objective of our project is to enhance the contents, the training structure, the materials of the Criança Feliz, to improve the quality of home visits. And the idea is that they will not only focus on home visits, but considering the difficulty of access and many remote meetings like indigenous communities, the idea is that we also expand to group meetings and to remote meetings. So the scope work is the same from the pregnancy to 42 months. But the idea is that we create a flexible and adaptable curriculum in terms of the frequency of the meetings that can be weekly or quarterly, and delivery strategies that can be home visits, group meetings, and WhatsApps. And we also need to adapt the content of the curriculum to different ethnicities and to children with developmental delays. And besides of that, we will design the training program and monitoring instruments. So in order to do that, we have been
So wait, this is,
working
just to understand, this is taking the Jamaican curriculum?
though this is based on the Jamaican curriculum, but it's not the Jamaican curriculum because it's not feasible in Brazil.
So how does
that's
it
what we
depart?
are working on.
I just
Sorry?
curious, how does it depart from the Jamaican curriculum?
Yeah, I will show you.
Okay, fine. Yeah, if you're gonna get to it,
yeah.
yeah.
So the idea is that the toy kit is not feasible. And because of the characteristics of the different populations, we have activities that are not used by some populations or by others. And I will give you an example. In the Reach Up, we have many activities that involve taking a baby bath. And in some areas, they don't do that. They don't allow the visitor to be part of the baby bath. In other areas, like indigenous areas, we have a lot of children accompanying their parents in the domestic chores, but in other areas, this is not allowed. So we couldn't use the Jamaican curriculum as it is, but we had to create a flexibility of the curriculum. So we have been working with 32 municipalities from 8 states. And the idea is that these municipalities will work with us along all the process, and they represent the diversity of contexts and populations of Brazil. So, and we chose these municipalities because they have beneficiaries from all the traditional communities that are covered by the PSF. And you will see that we have like a lot of different people, like we have indigenous, we have gypsies, we have riverband population, and rural and urban. So we created a group of municipalities that would be comprehensive enough to cover all these different contexts. And we are working, we know that in Brazil we have like 305 different indigenous ethnicities, but we have been working with 23 of them as an example of indigenous ethnicities. And that's why we cannot keep to the Reach Up curriculum, because we would have to adapt the curriculum to the cultural characteristics of each of the different communities and ethnicities. So what we have been working with is that we have mapped not only Reach Up activities, but activities that are used by this child play that is used by these communities. And we also mapped activities that are used by other Brazilian programs, so that we can create a compendium of play that can be used to prepare our curriculum. And the idea is that we have an interactive curriculum of activities according to development domain and age range, so that the visitor can choose which activity can be done for each family. So the idea is that we have this interactive map that will be transformed into an app, and he can select the activity based on the age range, based on the materials that we have, that we need. And this is an example why we cannot have a toy kit. So that's why the curriculum, the strict Reach Up curriculum and toy kit is not feasible, because we have so many differences. So the idea is that once we finished these new compendiums, which has many different activities that can be done with toys, without toys, using daily chores and other possibilities, we will test those in 2 pilots. So the first pilot will be the acceptability and feasibility test that we will conduct in 7 different municipalities that represent the traditional communities of Brazil and rural and urban areas. And the idea is that they have a small team, so only 1 supervisor and visitors. They will be trained and use the curriculum to see so that we can see our acceptability and feasibility. And after that, we will have a second pilot to assess efficacy, which is still under discussion. But the idea is that we will then compare our new curriculum to the current Programa Criança Feliz visits. We will randomize at the social service unit level. And the idea is to use the FCI as a measure of efficacy, because we won't be able to have a long time of the intervention to assess differences in child development. So the idea is to use parenting practices changes as a mediator of child development. So the idea is to have 2 large municipalities and 2 medium-size additional municipalities to be able to finish this second pilot that will take place probably in the second semester of next year.
Alexandra, one question is, what is the frequency here?
So the frequency of the visits, you mean?
Yeah.
It's weekly. It's weekly. But what we have seen in practice in the Criança Feliz is that the average number of visits is 2 per month. They cannot do the weekly meetings, and that's why we want to test a flexible curriculum that can use this weekly or quarterly visits.
Yeah,
that is more.
And then how are
likely
you thinking like to combine the individual and the group, like having like 2, like how is the frequency between the 2 of them? Because we are also wondering when to introduce the group sessions. We were thinking like now that we are implementing in Tanzania to do it like when the child is already 3 or so. So then before you concentrated on an individual for pregnancy and the first 3 months. And I don't know what is your approach on there and your knowledge.
We didn't decide it yet. But the idea is that we will have the groups with the same frequency of the home visits. We also thought about combining, in some programs, they combined visits and group meetings, and it seemed to work. But the idea is that we will test the group meetings from pregnancy on, and then we can decide if there is a difference in terms of effect on starting earlier or joining only when the child is older. We don't have.
So if I understand well,
yet.
you will have only groups with arms with groups or arms with individual, but it's not combined.
No.
I was wondering, like, I'm very curious, like, if someone could actually do that. Because, like, we are trying now, but it's not that we have evidence that it will work, but we know, like, our sense is that it will be much better because both of them have trade-off, no? Like the same that you discussed it before. So we don't want to continue just spending money with groups because we think that is not the best option. So maybe the combination of both, but we haven't found like evidence on it with the reshuffle or similar than the reshuffle. So for that reason, I was asking.
We have been discussing with Marta Rubio, probably you know her, and the idea is that we can use these pilots to test as much as possible. So we haven't closed the pilot design yet.
That will be great to have like a combined arm.
And what we did was we postponed the pilot so that we will have more information from the first pilot, and then we can plan the second. So, and in the first pilot, we will try group meetings and home visits too. So I think that they will inform our next step.
Alexandra, can you explain a little more? You said like in the traditional Criança Feliz, there's no curriculum. So what are people doing? Like, what are actually the visits doing?
This is a good question, you know. My father will say they are doing the best they can. So they have to decide on the activities. There is no structured proposition of activities. And this is the main problem, because they know they have to do age-appropriate activities, but the visitor, it's up to the visitor to decide what to do in each visit. And what happens is that they don't know they don't understand about child development enough. They don't cover all the development domains. So they don't use age-appropriate activities at the moment. So they choose whatever they do, and they use the internet. They use different sources for that. And the result
they
is that,
record?
no, they don't record. They should record. They have a monitoring document that's called the visit plan, but in practice they don't. So it's very difficult to know what they're doing, and in the end, the program is very heterogeneous, and we have seen a lot of mistakes. So, like as an example, they were trying to teach numbers to a child of 13 months.
Okay. I guess it would still like, how, like, are the records kind of available, and like how many percent have been filled? Like, because there must have been this huge search space for possible interventions that happened through these thousands of home visitors sort of Googling activities on their own. So
yeah,
you know.
Yeah, well, we asked for these 15 municipalities that we started working with, and then the 32 that we are working now, we asked for the plan, the visit plans, and we received less than, like, I would say 10 per municipality, which means that they are not doing it.
Okay.
So I don't think this kind of information has been used for the program evaluation. We had a program evaluation conducted by Cesar Victora last year, and it resulted in no evidence of impact of any kind, and that's why we decided to engage in this partnership with the Lego Foundation and us to improve the quality of the program.
Interesting. Very typical.
But is there some way to utilize the information on these different visits? I grant you that people are kind of taking different, they're essentially applying different curricula. If you had any idea of what they're doing, it could be interesting to characterize what the nature of those visits were. So, you know, I like the one, you have this kids are learning how to count when they're 13 months. Okay, they can't. So that's interesting to know, but there are some others that must have been right on target. So I'm just curious if you can collect that information and analyze it. That would be very productive, potentially.
Yeah, that's what we did with the mapping of the 32 municipalities and 10 programs. So we mapped all the activities that were that they use for their home visits, and from those we tried to select activities that are appropriate or to fix the activity for a correct age range, so that combine these compendium of activities that came from them with the reach up activities that do not require specific toys to create our curriculum.
Right.
So that they feel reflected in the curriculum, but also we provide additional support for them.
So what do you find, though, when you do the evaluation on the cluster of activities that are age appropriate? Do you find more effect?
I don't know. We didn't assess it yet, but I assume that, yes.
No, it would just be interesting to know. I mean, I think you really have a kind of randomization. If these people are ignorant, their ignorance is a basis for believing you have randomized assignment of treatments. And as a result, you could find some interesting outcomes about which kinds of treatments, which kind of interventions were effective. Anyway, I'd be very, very curious about.
Yeah. Yeah, and you know, they also have an instrument to assess the child development. It's not a very good one, and the problem is that they don't know how to assess very well the instrument of child development, but we have that. The problem again is that very few agents fill out the forms.
Right, I understand.
Yeah, but I could try to map at least some municipalities that have them, so that we could look at it.
Yeah. It'd be very good. Yeah,
Yeah.
certainly worth interest.
One thing that is good is that these 32 municipalities, they are very engaged, and they are willing to have us doing our research there. So it's a very fertile field now for us.
Yeah, I guess you could try to retrospectively collect this information, right? You could ask now, before you start with the new curriculum, you could have like a detailed survey of every field person, of every agent, and ask them to list activities that they used. So at least for these municipalities, you would have this record. And then, that could be one.
Mm-hmm. Yeah, I think that from next year on, when I will be able to travel to the municipalities, the contact will be better, because for now we have been doing everything online, and it's difficult to reach, especially the visitors.
Well, unless anyone has any last minute questions, we can thank Dr. Brentani.
Sorry, I have a last minute question. For the Boa Vista study, do you have any information on what kinds of mothers or families or kids benefit more from the program? Say, do you find teenage mothers tend to benefit more?
We don't have that information yet, but this is one of our goals, to see where, to which population the two models fit best. So yeah, in the beginning of next year, I can tell you that.
Because from my research on Google, I find that abortion is actually illegal in Brazil, right?
Sorry? The
abortion.
population, you mean the refugees?
No, the abortion is
abortion. Yeah,
it's illegal in. So I would imagine many of the kids that, if pregnant, wouldn't be born in other countries, may be born in Brazil. I would imagine these families tend to be most vulnerable in terms of childhood development.
Yeah. Well, abortion is illegal, but still it's widely practiced.
Okay, I see. Yeah,
that's common.
I get it.
Yeah, that's common. It's poorly enforced.
Yeah, and sometimes you can have ways to get rid of the babies.